Hello, and welcome back to the second lecture on clinical interviewing. Today, we are going to be looking at establishing rapport during a clinical interview, and this is going to begin to build upon the first lecture. So let's jump right in. Uh, Rapport is of course something that we need in therapy, that we have to know that the client trusts us, and we have to have a good feeling about the client themselves. So during a clinical interview, this is the beginning part of the counseling process. How do we help clients get comfortable? Because I can almost guarantee you that most of the people that come in for therapy might be feeling a little vulnerable, and a little unsure, and they don't know who we are, and they don't know what to expect. And another question we need to ask is, not only how do we help get the client to feel comfortable, how do we keep ourselves comfortable during this time, because we might be feeling a little vulnerable, because this is very much a forced relationship that breaks the law of self-disclosure. So first off, let me just talk about the forced relationship. That this is something that somebody is coming to see us, and they are going to tell us a lot about themselves, and that's and then we are going to attempt to create some kind of a clinical rapport with them. So it's very forced. This isn't just meeting somebody someplace and getting to know them in a natural way. This is a very artificial type of a relationship between two people. And the law of self-disclosure is very broken here, because the law of self-disclosure states that in a normal relationship, when you get to know somebody, that I would tell you a little bit about myself, and then you would tell me a little bit about yourself, and then I'll tell you a little bit more about myself, and it just keeps going on a little bit, on and on, where where two people are sharing with each other who they are and what they like and what they don't like, and as time goes on, the material gets a little deeper and a little bit more intimate. But in therapy, the content pretty much gets pretty deep and pretty intimate right away, and it's only one-sided, that the client is telling us about themselves, and we're not sharing too much about who we are. So this is a very weird relationship to have with another human being. And the thing is that we have to make sure that we're helping them feel as comfortable as possible through this process. And because they might, they're going to be wondering, will this therapist judge me? And maybe we as therapists are thinking, are they going to judge us? Are they going to like us as people? And that's a very human trait. I know that it doesn't matter if they like us or not, from a counseling perspective, but from a human perspective, we want our clients to like us, and I think we ultimately want to like our clients. So these are the different approaches that I'm going to talk about today in terms of developing rapport. Putting yourself and the client at ease, finding their pain and recognizing it. Look for insight and play on it and become their ally. You being the expert in the relationship, also the leader, at least for now. And also finding a balance in the roles of clinician and client. So there's a lot going on in developing a clinical rapport. So let's get started. What things might you feel anxious or unsure about with this new client? Also, the client often doesn't know what to expect. They don't know who we are, what we look like, what our style is going to be. And maybe they had therapy in the past, and they're going to have all their expectations based on what they had in the past, and they're not sure if we're going to meet up to it. Or maybe they've never been in therapy and they don't know what to expect at all. Is the therapy voluntary? Are they coming in on their own accord? Do they want to work on things, or is it mandated? Is this court ordered, or maybe their spouse is twisting their arm to get them in? I guess why are they there? Do they want to be there, or do they not want to be there? And whether they want to be there or whether they don't want to be there, they're still going to be skeptical about the process. They're going to be skeptical of you. they're going to be apprehensive about the process and maybe you, and they're going to be nervous overall. Um, they might be asking, will they, will this therapist judge me? Will they understand me? Are they going to get me? Are they going to, get where I'm coming from? But then at the same time, the therapist is going to be asking the same question. You will be asking, are they going to judge me? Are they going to understand me? Are they going to accept me for who I am? And once again, from a professional standpoint, that doesn't matter. But from a human standpoint, it very much matters. And it can also bleed into the clinical interview process if we don't acknowledge what is going on within us and give it space. So and the thing is that putting yourself in the client at ease, the first place that I like to start, or at least talk about, is begin with a very open and inviting office. So you have to make this home for you. And you got to make it, the lighting has to be right, the colors on the wall have to be right, the furniture has to be comfortable and nice, there has to be things on the wall. You need to develop the office in a way that says, this is who I am as a person. Because therapy is not a one-way street, that there are going to be things that they will know about you. And I think in an inviting office where you're willing to share with them on some level who you are, can help put the client at ease. That if you have pictures on the wall or things that you like, and the thing is it's a great way to connect with them. That I used to have a guitar in my office. I'd play the guitar between sessions, and people that would come in that were musically inclined say, "Oh, you have a guitar," and we'd talk music for a little while, and that would help build rapport and put them at ease, and also put myself at ease. Or if I had works of art on the wall, that we might talk about about the work of art or whatever. So an open and inviting office is very important. Please put some of yourself, your personality and your identity into your office so they feel like you are a real person. Also, small talk. When somebody comes in for that first session, and they're walking through the door or walking down the hall, and you greet them, you would say, like, hi, Sarah. Hi, I'm Tom. And some people like the formality of doctor. I don't. They always ask, well, they might refer to me as Dr. Foster, and I might say, oh, please, you can call me Tom if you want. Or if Dr. Foster is something that they would feel more comfortable with, then that's fine too. But I think I would say 9.5 times out of 10 that people are going to want to be able to call you by first name, and maybe not wear that suit and tie to the office every day. To that if you're dressed to the hilt and you're seeing clients that can't afford to be dressed very well, then that puts a distinction between you and them. That puts a barrier. So maybe dress to your client's level. In a sense that you want to look nice and respectful and professional, but you don't want to look like you're flaunting money or wealth, that you don't want to be out of touch. I also say with small talk, in terms of, when they come in for the first time, I say, like, welcome to my office. Please, make yourself comfortable, sit wherever you want. And also at that time, you're also, you're assessing them for where they do sit. So from the time that they open, that they shake your hand and you say hello, you are assessing them. And we're going to talk a little bit about that as we move forward. But the small talk is important because it helps to make them feel at ease, and it puts you at ease, that you're not just going to get right to it right away. Like, please come sit down here, and I'm going to ask you a bunch of questions about yourself. Did you find the office okay? My old office was just above a bakery, and it always smelled like cookies when people came in. And we always, clients that would come in for the first time, that we would always like to laugh about how the office smells like cookies. And I always said, yeah, that's free. That smelling the cookie smell is no charge. And they would laugh, and I would laugh, so, but really, what you want to do is you want to create some kind of element of small talk and some kind of formula that you can fall back on, that you can do it in your sleep if you need to. So small talk, very important. Watch for cues at this point. Some people want to take things slow in therapy, and others want to get right to it. I've had clients both ways, and mostly people are in the middle. But you want to follow their lead, and sometimes they want to go maybe a little faster than what they can handle, but they don't know it. So you need to kind of pull them back a little bit, but not too much, because you want to make them feel like like they have some say. And then other people are going to be dragging their feet a lot. So but you just have to watch. You just have to pay attention and see what they need. um, Putting the client ease, it also is letting them know about the process of therapy in general, but also the clinical interview specifically. When I'm in, oh well, it hasn't been that long, but when I was in private practice, I would talk about how I'd say, look, we have, this is the first session, and we're going to start out with, we're going to do the clinical interview, and we're going to, I'm going to assess some things. But first, we need to talk about some paperwork. And I would always tell them, since this is private practice, we don't have, as much paperwork as if you were coming into a mental health center and with dealing with insurance and all that. So you have to introduce them to the paperwork that is in front of you that you need to. So if it's insurance stuff, talk to them about the insurance stuff. If it's the declaration of practice form, which is a form that all LPCs in the state of Louisiana have to have and give to their clients, and you would go through that with them. If this is just and then talk to them about the intake and explain what the intake is meant for, and explain to them that the intake is going to ask very general questions like their age and their demographics, but then also it's going to get into different dimensions of their life, and you can let them know that the intake is meant to help you catch up on the last several years of their life, so you can understand them better, so you'll be able to help them in a better way. So if you explain everything to them as you move through it, that will make them feel better, rather than you just getting right to it and them second guessing, well, why am I doing this? Why do I answer this? And that's going to make them feel anxious and a little distrustful. Yeah, like I said, explain how the clinical interview, or why the clinical interview is important for their treatment. That like it is like they are the experts of their lives, and they know what they've been through, but we don't know, and we need to understand them on a lot of different dimensions, and how you're gonna play catch up as quick as possible, because you know that they want to get to why they're here, but you need to start all the way back at the very beginning, that that led them up to them coming to your office. Also, let them know about some of the questions are going to be personal, and and maybe a bit intrusive, and you want to let them know that they can either say pass. They don't have to answer them. Just say, no, I don't want to answer that right now. Or if we ask them, like I always say that there's answers about abuse, about verbal abuse, emotional abuse, sexual abuse, physical abuse, and neglect. And I said, look, if I'm going to ask you about these things at some point, but you can just you don't have to answer them truthfully. You can lie to me, and that's okay, because you might not be ready to talk about them, and we'll just move forward. And that always kind of blows them away, that you're giving them that option of just saying no, like either no, I don't want to talk about this, or just lying about it and not being truthful. And I think it helps them feel a little bit more empowered. Like, yeah, I don't have to tell you anything in here if I don't want to. So, and that's the truth of it, is they don't have to tell you anything. And during the interview process, you can self-disclose if you think it might be helpful for the process. And when I say that, like, of course the session shouldn't be solely about you, but if you're asking them about their their nuclear family, and they talk about how they have dogs in their family, that's when I would perk up and say, oh, you have dogs? What kind of dogs do you have? I have dogs too. I have 2 greyhounds. And then we talk about dogs for a few minutes, and that just once again helps put the client at ease, lets them know that you're an approachable human being that has a life of their own, and that that you might be more relatable. Finding the signs territorial signs. How do they enter your office? Like when they walk in, do they walk into your office casually, or do they walk in very quickly without shaking your hand? Where do they sit? Do they sit in the corner? Do they sit in your seat? Do they greet you, or do they avoid you? Eye contact. Do they shake your hand? Do they walk around your office and play with the stuff on your shelves? Or do they just sit down and look straight down? You have to think about all these things and just watch for how they're interacting when they first come in. Psychomotor types of issues like eye contact. Do they have psychomotor agitation or retardation? Are they fiddling with things, or do you feel like they're being overly intrusive to your space or to the things in your office? So also some emotional, looking at emotional features like their posture, their gestures, facial expression, tone of voice. Verbal, representing problems in certain verbal ways that are either have visual characteristics, auditory, abstract ways, like if they're talking about their primary problem that they're coming in with, and they're saying things like, well, I don't see a way out of this, then you might want to start to parrot that behavior, that verbal pattern of asking them, when did things look so bad? So there's that can help put them at ease, and maybe not in a direct way, but more of a subtle way, that if you're really listening to how they're speaking and following that and using those types of metaphors. Also, attire. Notice what the client is wearing. Are they coming in dressed professionally? Are they coming in dressed casually? Are they dressed inappropriate for their age? What is their hygiene like? Notice how a client smells. Notice their oral hygiene. Notice their, all of it. Okay. At this point in the therapeutic relationship, this is really just the first session. So you're just going to notice things right now. You're not going to start calling people out. You're not going to start asking about some of these things, not until you feel that you've developed some kind of a stronger working relationship with them. So just notice them. And when the time is right, I can't tell you when that time is going to be right, but you will know. You have to ask them about specific signs that you're seeing, and talking about it. And the thing is that you'll know when your intuition tells you, when you feel it's the right time. I would not use any heavy-handed type of psychological jargon, especially at first. So if somebody's coming in and they're saying things like, oh, I just can't sit still, my legs are always moving around, I have to get up and walk around, and you ask them to talk about that and say, well, how long have you had this psychomotor agitation? They're gonna be like, what? Like quit throwing these words around, trying to make me feel like, trying to make me feel stupid. Just I think it's important that you learn all of the the psychological jargon, but in this, at the very beginning at least, you got to throw it all out the window. So that way you're helping to keep the client feeling more at ease. Always let clients during the clinical interview go off on small tangents during the intake. Number one, it helps them to take a break a bit. And if things get to be too much for them, they can kind of go off and do a tangent, and it gives you a little break, and it's a great way to maybe connect with them on, in a different way. So, and that's fine. But the thing is, you eventually, you can steer them back to, what you need to ask them and work on for the clinical interview. So for example, you could explore with them different things, like, and I already talked about the pets example. If what school they attended. I know in New Orleans, what high school you attended is a big deal down here. And when you meet somebody, they always say, well, what high school did you go to? And I don't know, it's just what they do. I remember there was one example that I was doing a clinical interview with a guy, and we got to the questions about drugs and alcohol, and I asked him. I said, "Well, do you drink?" And he's like, "Well, yeah, I drink." And then he started going into a little bit about things that he enjoyed drinking, and Scotch was one of them. And Scotch happens to be something that I like, so. And he was kind of going off on the tangent anyway, and I was, and so we had a nice, maybe 3 or 4 minute conversation about Scotch, and I think I noticed that after we had that conversation, that brief conversation about Scotch, he was much more open in the session, and he was much more relaxed, and that was about halfway through. So it was that was a great tangent to go off on with him, just for a short period of time, that he was able to feel more connected to me. Finding their pain. Typically, this begins with, asking the question, and there's so many different ways to ask it, but when you ask them, okay, why are you here right now? That you can ask, what brought you in today? How can I be helpful to you? What is it ultimately that you want to work on in here? In a lot of different ways to ask it. It's always great to ask it in an open-ended manner, but this ultimately gets to their pain. It's called the primary problem or the chief complaint. And this is a point where you need to put your pencil down and just sit with them. And I always tell them, like, maybe over the next 15, 20 minutes of the intake, of the session, maybe you can, give me a brief description of what brought you in today, and what you want to work on. And then you just sit back and listen. You let them vent. This is going to give you insight into their subjective worldview. This will make them feel better because they're actually venting some of what's happening, and it's also going to help develop rapport between you and them, especially if you're listening and paying attention. And also, you'll get to see the level of their pathology through this, and their level of insight and things. So this is the point where you're just saying, okay, level with me. Why are you here? What's going on? And then you go from there. And as they tell the story, because there's really 2 things that you need to do when you get to this point. You need to get them to tell their story, which is the psychosocial details, but then also inquire about their diagnostic symptomology, in terms of if they're coming in because they're depressed, but then they're also coming in because their marriage is failing and they might lose their job. Then those are two different sides of the same issue. That that the psychosocial issues are, my wife might leave me and I might get fired, but the diagnostic part is the depressive symptomology. So you need both sides to really understand what's happening. Don't just ask about the psychosocial details to get the story. You need the diagnostic profile to know how the story is affecting the depression and how the depression affects the story. So you need to ask about the severity of the symptoms, the length of time that they felt depressed, and when did they start feeling depressed? Because if you don't get that, you might have completely missed the fact that they've been depressed since they were 15 years old, and they're coming in and they're 28 years old now. So they've been depressed for 13 years. But if you're only looking at the fact that their wife might leave them and they're on suspension at work, man, this problem has been around for so long, and it might be getting worse, diagnostically at least. Always express empathy and interest. Ask them to expand on things, get clarification for other things. Because you are trying to connect with them on an interpersonal level at this moment, but you're also trying to get as much content and content that's clearly stated that you understand as much as possible. So this is a lot. This is a lot to juggle. Also, how do you, one question that you have to ask yourself is, how do you specifically express empathy? We all do it in different ways. So I think that's something that you need to think hard about. How do you empathize? How, in what way do you do that? And how is that demonstrated to the client ultimately? So finding insight and being an ally. What level of insight does the client have towards their problems? Um, so full insight is something that I think we all strive for but don't have. The degree of their insight, if we subtract full insight by the degree of their insight, then we have what is known as a reality testing. In terms of how much do we understand, or how much does the client understand the full grasp of their issues? Like, how much insight do they have into their depression? How much insight do they have into their failing marriage? And hopefully the more insight the better, but none of us have 100% insight. So we just need to determine if somebody's coming in with 80% insight. um, that's not bad compared to somebody who has 40% of their insight. So the less the level of insight, the less that they just have a sense of reality or a firm grasp of reality, and which is going to make prognosis a little bit more difficult. So levels of insight into their symptoms: full insight, full awareness of their symptoms, and are part of their disorder. Symptoms are known as are ego dystonic, which means that they're very unpleasant, and the client wants to get rid of them. Partial insight: this lacks some awareness that symptoms are related to a disorder, or they deny the impact of the symptoms. So they're either in denial that these symptoms aren't really bothering me because maybe this is their symptoms are their drinking. And it's like, oh, my drinking isn't it's not having a bad influence or impact on my health or my relationships. Uh, but then lacks some awareness that the symptoms are related to a disorder. That there's some disorders like OCD that people may or may not realize that their OCD symptomology is part of a disorder, that they might actually have some kind of a buy-in that their symptoms are real. And I don't mean that they're not real, like they experience them, but that it's part of an OCD diagnosis, and not and maybe something else. So no insight is when they have a complete lack of awareness, or they deny they have symptoms at all, or a problem, or that they're even suffering. So if somebody has very little insight into this, then the symptomology might be more egosyntonic, which means that it might feel okay. Those symptoms might feel okay to the client. So somebody with a personality disorder might, typically people with personality disorders, they're very egosyntonic. That narcissistic personality disorder, for example, that they don't really have a problem with how they are in life, that they're fine the way they are. It's the rest of the world that is the problem. So they're fine with them, but it's just the rest of the world that they have to contend with. Okay, so understanding a sense of insight, or understanding how much insight a client has, is going to direct how you might ask your questions. So let's say somebody with schizophrenia comes in, and they're telling you about all these hallucinations, but they're describing it as part of their, as part of why they're coming in. If they have full insight, they're going to know that the hallucinations are not real. And you can ask them, how long have you had these hallucinations of demons? But somebody with no insight, you might want to ask them, you might want to reword the question: how long have these demons been bothering you? So you have to make sure that, because if you address somebody with no insight that thinks that these demons are real, and you ask them, well, how long have these hallucinations of demons been bothering you? They're going to look at you like you're crazy, and they're not going to like you very much, because you're basically calling them out as crazy. So you need to make sure that you understand how much insight they actually have. And it's just basically following the phenomenological perspective, like the slide says, that whatever their worldview is, and their level of understanding to their subjective worldview, then you would be right there with them. Oh, don't see the whole person as sick. I mean, there's certain parts of us that might be less healthy, but always appeal to the healthy part, and how we can help aid and treat the sick part. And it's going to depend on their level of insight as well. So somebody with full insight into their hallucinations, you might say, well, let's get you on some medications to help reduce the hallucinations to ease your distress. And they'd say, okay, that sounds great. But somebody with no insight, you might say, well, let's get on some medications to help you reduce your anxiety that you have about these demons. So that way they feel like you're hearing them and you're on their side. Okay, the next part is being the expert in the room. And what I mean by that is be an expert in the room, not the expert. So you and your client are both going to have your expertise in different things. Now, you're going to have the expertise in human behavior, theories, assessment, treatment, diagnostic. You're going to have your master's in counseling, and then you're going to be able to bring that to the table. But they're going to bring their expertise in themselves. I always tell people, like, I have the PhD in counseling, and I describe all the stuff I just did, just a second ago. And then I tell them, I said, you have the PhD in your life, and you are going to bring that to the table. And there's going to be times that I'm going to be the expert in the room when we need, all of the psychological jargon and mumbo jumbo and theory coming up. And then other times they're going to be the expert in the room, and they're going to bring their doctorate in, their PhD in them, that they're going to be, that you're going to rely on. So, and the thing is you have to sell yourself as the expert in what you know. And so I think part of it is having a spiel of how you can sell yourself as the expert, so that you can show the client that you're competent in handling their problems and working with them. So, as the novice, you're going to say things that are a little different than the seasoned professional. And this might be something that you might want to script out and write about, and find what strengths you have as an intern as you move in, to your clinical practice. What can you hang your hat on versus what maybe a seasoned professional can hang their hat on. Things to do as an expert: universality is making sure that they know that they're not the only ones with these issues, and that people have gotten better. So a lot of times people come into therapy because they think that they're the only ones that feel this way, or, oh my God, I can't imagine anyone else feeling this way. I'm the only one. And if you sit with them and you tell them, say, look, I've worked with people with the same symptoms as you, or had the same trauma background as you, or whatever, and to let them know that those people worked through a lot of those things in therapy and felt a lot better, that they don't feel like they're the only ones. Like, that's why I like diagnostics sometimes, is because somebody comes in with all of this anxious symptomology, and then you diagnose them and say, well, look, you have generalized anxiety disorder. A lot of people have this disorder. And, a lot of people develop this because of such and such, or this or that. And they walk out feeling like, oh, I'm not the only one. So also show knowledge about their illness. So, asking about their symptoms, talking about biological and psychological etiologies. This is going to come from your theoretical background. This is going to come from your counseling training, that you want to convey to them that what major depressive disorder is, and what your about what your form of treatment is. So you need to let them know that you know things. Discuss any doubts that they might have about your clinical skills. Be open and accepting about this. Some people are really going to grill you, others, maybe not. But talk about your training and how you, serving as a clinician, as their therapist, are going to be different from talking to mom or dad or their friends, and how it can be more helpful. And then also, try to instill some hope into the process. Talk about any past experiences you had with this disorder, and how treatment has been, was very helpful, and maybe can help them as well. So part of it is when you sell yourself as the expert, you got to do it. You got to do it well. They have to walk out of that first session feeling like, hey, this could really work. Establishing a sense of leadership, it doesn't mean taking over. It means motivating and guiding by letting them know what you're doing. Um, that I always try as a clinician in the sessions to demystify the therapeutic process as much as I possibly can, and that it's a collaboration. That it's me and that other, and the client working together. That, I'm not going to mystify this process. I'm not going to be sitting up on some high chair and looking down at them. This is two people in the trenches together. They have their strengths in this process. I have mine. We're gonna, and everything's going to be very concrete and transparent. Balance out the roles. The clinician's role is going to be to, you got to find a balance between your roles. Sometimes you're going to be the listener. Sometimes you're going to be the expert. Sometimes you're going to be the authority. Sometimes, like what I tell my clients, I say, look, the only time I'm ever going to blow the whistle on you and get to the point where you might not have a choice on things is if there's any kind of imminent suicide or homicidal type ideation. If there's been child or elder abuse or animal abuse, then that's when I blow the whistle. But that's really the only time I become like an ultimate authority, and no exceptions. So the client's role, there's several roles that they could carry, or they could that they could take on. The first one might be the carrier of the illness. Or does not associate directly with the illness. They might look for expert advice over empathy. They might be looking for you to say, okay, his problem is not him, but is his job. So, what's the carrier of the illness? The sufferer. This associates directly with his illness. They want empathy and compassion, and they want help. They also, there's also the VIP. They see themselves as important and entitled to your attention and time. Very little boundaries. They're going to be the ones that are going to be calling you at 2:30 in the morning because they can't sleep and they want you to do therapy at 2:30 in the morning. So there's always that. Interacting the roles, depending on which role the client is taking on, at whatever point, the clinician must counterbalance with the appropriate role. So when the client is upset, you're the listener. When the client needs information, you become the expert. When the client, needs a push, then you might be the authority. So, all right, this has been the lecture on. This has been the lecture on establishing rapport during the clinical interview. This is an especially important lecture, I think, in terms of, how do you connect with someone during the clinical interview? Because I think a lot of times it's a lot of info gathering, but it's so important to get this info, but also to establish rapport and at the same time. So hopefully you've gotten something from this. If you have any questions, please reach out through email. Okay, have a good day, everyone.